Good evening, and thank you for joining us for tonight's virtual education event, ROSA Knee Robotic Technology and Persona IQ Smart Knee Implant. If you have any questions during this evening's event, please post them in the Zoom chat window, and we will address them during the last 10 to 15 minutes of the event. If you have any questions after this evening's session, please feel free to email them to outreach@capecodhealth.org, and we will follow up with you directly. To learn more and view tonight's recorded event, please visit us on the web at capecodhealth.org/knee, where this presentation will be posted within a week. It is our pleasure to introduce tonight's speaker, Dr. Paul Dimond of Falmouth Orthopedic Center, an experienced board-certified orthopedic surgeon who has practiced in Falmouth for over 26 years. Dr. Dimond earned his medical degree at Vanderbilt University School of Medicine, completed a residency in orthopedic surgery at Brown University, and completed fellowships in trauma at Rhode Island Hospital and in hip and knee replacement at New England Baptist Hospital. Dr. Dimond's clinical interests include total hip and knee replacement, total joint revision, osteoarthritis of the hips and knees, and trauma surgery. At this point, we welcome Dr. Dimond to begin tonight's presentation on the latest advances in knee replacement technology now available at Cape Cod Healthcare.
Thank you, Julie. Thank you for that welcome and introduction. Thank you. Before I jump into tonight's lecture, I want to welcome everyone to coming tonight. I appreciate everybody's attendance, and I'm looking forward to sharing some very interesting and exciting information about knee replacement. But I wanted to start off tonight with just a story. As I was getting ready tonight, a patient called me on the telephone, and she had her total knee replacement 1 week ago, and she said that this knee replacement was significantly better from a pain standpoint and a range of motion standpoint than the one that she had had 7 years ago. So we're going to dive into that tonight and talk about why I believe it's better now and why I feel she was so excited with not only her knee replacement, but as I'll talk tonight about her app on her telephone that allows her to kind of be guided through exercises and things that we can do from a distance. So very exciting technology. The name of the talk is New Developments in Knee Replacement, ROSA Knee Robotic Technology with Persona IQ, the Smart Knee Implant. Let's go forward. So the outline for today, I'm going to review a little bit about knee arthritis. I'm going to mention some basic treatments. I'll talk to you about surgical indications, and I'd like to give you an overview of what we're doing in Falmouth and our protocol in Falmouth at Falmouth Hospital. I'll talk to you about the My Mobility app, and I'm going to go into detail about the Persona IQ Smart Knee Implant, and I'm going to talk to you a lot about the ROSA Knee Robotic Technology, how I do that operation, and how I see it really improving patients' outcome and the benefit to it. And I'm also going to talk to you a little bit about what I'm seeing in what's called the recovery curves. Let's jump right in. We have a picture there of the ROSA robot and the knee replacement, but I'm going to show you that in more detail as we go along tonight. So arthritis means inflammation or swelling of the joints. There's multiple causes such as wear and tear, inflammatory disorders, trauma, infection. And osteoarthritis is by far the most common type of arthritis that I see. The end result is a painful, stiff joint. And you can see, my pointer isn't working as well as I would like, but you can see the x-ray to your left of a normal knee. It's the femur and the tibia, and the space between those two bones is the normal cartilage, and the cartilage does not have any nerve endings, and as that cartilage wears away, the two bones will grind together, and the bone ends have nerve endings which then cause the pain. So to your right, you can see a preoperative x-ray of a knee that I'm getting ready to replace. That knee is bone on bone, and part of the arthritic process is that as the arthritis progresses, the knee will become weaker and more ligamentously imbalanced. And I will get into more detail with that as we go along. So 23% of the American population has a diagnosis of arthritis. And if you look at the slide in front, you can see that the amount of patients that we're seeing in the country with arthritic conditions is continuing to grow. So treatments, at the my last YouTube video, I did give a in-depth lecture about the conservative treatments for knee arthritis. You can see that on our joint innovation lecture that I gave the last time. But I typically take a conservative route first. We'll start out, if patients present to the office with inflammation and pain, we'll start out with a cortisone injection to help alleviate some of that initial flare-up that arthritis can have. And then when I'll follow them, patients in the future, there is a medicine called hyaluronic acid, which is a type of lubrication. I call it the WD-40 for the knee. That lubrication is given in weekly preparations for 3 weeks and can help also lubricate the joint and make patients feel better. As I mentioned before, what happens in an arthritic knee is that the ligaments become more imbalanced and the patient can get weakness associated with that arthritic condition. So physical therapy to strengthen the muscles around the knee, stretch the hamstrings can also be a very good treatment to help the arthritic patient's knee pain. And then bracing to give some support. I typically use bracing in patients who have malalignment with their knee in what's called varus, where the inner side of the knee starts to break down. And if that knee has some ligamentous instability, we can put a brace on it that allows the knee to feel more stable to our patients. So again, as I mentioned, I'm on a prior YouTube video, so if you want to go into more depth with those treatments, I encourage you to check out that prior lecture. Also, in that lecture, there are some talks about my experience with PRP, which is platelet-rich plasma, as well as stem cell treatment. So those are all conversations that I would have in the office with patients after a good history and physical examination, and then be able to go into much more detail than we have tonight. I have more exciting things to come. So surgical indications, typically patients who are ready for knee replacement will have severe pain that's not responsive to conservative care. And you'll see a loss of function that significantly impacts their daily living and malalignment. So I'll have patients, and you can see to your right, there's a patient with a malaligned limb where the arthritis has affected the lateral compartment of their knee and their leg is sticking out to the side. And not only does this patient have significant pain, but they also have a leg that is malaligned and prevents them from walking and functioning. So then you can see on the right side bottom, post-operative, the leg now has a knee replacement, as well as the patient's leg is now straight, allowing for the center of gravity to be directly over the feet, which allows this patient to then function. So knee replacements in the United States, we're seeing 1 million of these surgeries per year now. So there's a lot of knee replacements going on throughout the country. The prediction is that there will be 3 million knee replacements by the year 2030. And I use the Persona total knee replacement with the Persona IQ and Smart Knee implant. And if you look at the picture, and then I'll show you, I brought a model tonight to show you, but if you look at the picture where the knee replacement is, and first let me just show you this. When I'm done with knee replacement, the knee actually flexes and extends with a metal cap on the femur and a metal liner on the tibia with a plastic articulation between the two, both the femur and the tibia. So this is how the knee bends when I'm done. Now, what I wanted to show you is that the implant that I'm cementing in when I do it has a smart implant on the bottom, and this is what transmits the data for the patient to see on their phone, as well as the surgeon to actually analyze that data. More to come on that as the night goes on. So I want to go through the protocol at Falmouth Hospital, what the patient is experiencing, and how we work through the process of knee replacement surgery at Falmouth. So the day that the patient books the surgery, our surgical scheduler helps them sign up on the My Mobility app. This app has several exciting features. Those are a 30-day surgical countdown. So the patient will get alerts to their cell phone that says what exercises to do. We expect these certain exercises to get you ready for your operation. Those exercises all have a video associated with it, so the patient can actually look on their phone, see the videos. They can do the exercises they see. They can stick with ones they like. These are exercises that I have all reviewed and ones that I think are best for the preoperative situation for getting the patient ready for knee replacement. On the app also is a list of their times when they need to go to their appointments for primary care. That's for medical clearance as well as cardiac clearance. What medications to stop and when. For example, 3 days before, I'll have them stop their blood thinners. And this is all within their cell phone and part of the technology that we're using. And you can see this actually leads to an incredible amount of patient engagement. They're actually hearing the alerts, they're reacting to those alerts, and I can actually follow on my computer how they're doing and whether they're following our instructions. Gatorade hydration, when to take the drink before surgery. And one of the things that we've done at Falmouth is we've been able to get our joint replacement surgeons together and standardize our protocols so that all of this information that is plugged into the cell phone of my patients also goes into my partner's patient's cell phone, and the standardization of care also is what I believe leads to a better outcome and a happier patient. So, day of surgery, the patient will report to the operating room, and one of the things that I mentioned just as I began, the patient who had their knee replacement 7 years ago now really reports an improvement in their pain. And I'm going to describe all of the things that we've done that are different to help their pain and to get them home, okay? So multimodal pain management, every patient gets 1,000 milligrams of IV Tylenol, 200 milligrams of oral Celebrex if they're not allergic. And what we do is we do what's called an adductor canal block. Our anesthesiologists who are at Falmouth Hospital do a block of the saphenous nerve, so it numbs up the anterior portion or the front of the patient's knee before the operation. They also do an IPAC block, which is a infiltration of pain medicine between the popliteal artery and the knee capsule, also done under ultrasound, which you can see to your right. And that gets the sensory branches of the peroneal nerve to the back of the knee. And I want to give a shout out to our anesthesiologist, Dr. Villasant. If you're listening, you guys have been doing a great job with these blocks, and patients have been very comfortable. So anesthesia here is a key player in helping us get patients comfortable. So intraoperatively, once the patient's block is done, the patient goes into the operating room, they're given a spinal anesthetic, they are awake and sedated during the operation. This is a short-acting spinal. It lasts about 2 hours while I do the operation. It lowers the blood pressure into a very good range that prevents bleeding. So most patients do get spinal now. And when they come out of the operating room, their pain is controlled, they're awake, they're alert, they're ready to have a cup of coffee. So I'm also giving patients IV before surgery and intraoperatively tranexamic acid. It is a medication that prevents clot breakdown and leads to less bleeding and less swelling. So another way that we're controlling pain, controlling swelling, and getting patients in a good zone after their surgery is over. So, and the final piece that I do is after every surgery, that when I'm done and about ready to close the joint, you can see in this picture, I'm injecting bupivacaine. It's liposomal bupivacaine. It's actually dissolved in a fat carrier that slowly elutes out over time into the patient's soft tissues. And that can last up to 72 hours. So with all these combinations, now we're getting very good pain control. And I am sending now patients, 85% of the patients who I'm doing knee replacement home, same day. So, and we'll talk about that rehab protocol at the end of the lecture. So I want to jump now into surgery with the ROSA and the knee robotic technology. Again, very excited about this. This has been a 1.5-year journey, and it's been exciting, informative. It's been learning for me as well, but I'm really seeing fantastic results and, again, things that I want to share with you. So the picture to your right, you can see the setup. The ROSA robot is all the way to the right. Up in the upper left corner of that picture is the infrared camera. And then to the right, both on the robot and to underneath the camera, is what's called the planning screen, which I'll describe. And all of these pieces of the robot are talking to one another and understanding your personal knee anatomy down to the millimeter, okay? So surgery with ROSA, we have the patient in the operating room, and I expose the knee joint, and then I put in, you can see on the tibia and the femur in this knee, there's these trackers, and these trackers are what is seen by the infrared camera. So we expose the knee joint, then we place the surgical trackers. The next step is to use a pointer. So during the surgery, I have a pointer that points to areas in the knee, both the femur, the tibia, and all of the very important anatomical points to register in the robotic brain exactly what the knee looks like, how much bone loss there is, how much cartilage damage there is. And I also take measurements of the motion of the patient's hip to perfectly know the anatomic center of rotation of the hip joint so that we can plan where we want to make the cuts during this operation. So it's, and a buddy of mine from Zimmer Biomed gave me this term and I love it. So shout out to Scott. It was a personalized alignment. So for each patient, they get personalized cuts, personalized alignment, and I think the best result. So as you can see here, to your left, there's a knee that has what's called varus malalignment or damage to the medial side of the knee. So that knee, the ligaments, as that knee collapses into that position, the ligaments will get tight on the inner side of the knee, and they will get correspondingly lax on the outer side. So each patient with different arthritic situation has different ligamentous balance. So what I do before we even make cut one of your knee is I assess the ligamentous balance of the knee, both in extension and then in 90 degrees of flexion. And that information is translated into the robotic brain. So now I have a perfect, basically, in my mind, a matrix look at your knee, and I know what the ligamentous balance is. Then, well, before I mention that, I will say, ROSA Robotics ligament testing, each arthritic knee has different ligamentous balance. So I showed you that picture in the last slide of the knee that was bowed medially. This knee is what's called a valgus knee, and you can see to your right, there's a significant amount of bone loss and cartilage damage on the right knee, and that knee leads to tight ligaments on the outer side of the knee and a more correspondingly loose ligamented medial side. So those two knees are polar opposites of one another, and they need to be addressed differently, and that's where the robot comes in. I'm addressing these knees much differently than we have in the past. So this intraoperative testing, in my mind, is crucial to understanding how to reconstruct your knee. So then before, again, haven't made one cut on this patient's bone. Before we actually make that cut, once all the anatomic measurements are finished, the ligaments have been assessed, we manipulate the tibia and the femoral alignment. So on the planning screen, which you can see to your right, I'm able to, I'm hoping you guys can see this, but I'm able to tip that femoral component. Can you see that? Pretty good, you got good. So we can tip it side to side or varus valgus to know what the extension and flexion gap will be based on that movement. We can also move the tibia side to side to see what that's going to do to our ultimate flexion and extension gaps. And essentially what I want you to remember is that my goal as a surgeon is to make a perfectly rectangular total knee replacement. In other words, the gap in flexion and the gap in extension are perfectly symmetric, and that we believe leads to the least amount of wear and the best outcome for knee arthroplasty. So we can tip it side to side, and I also can move the femoral component in space up and down, and I can also rotate it to know how that affects the flexion gap, the extension gap. And then, again, before I make a cut, I know now on that planning screen exactly what I'm going to get before I even have started the operation. So I think that's an incredibly powerful incredibly powerful way for a knee surgeon to be working. So ROSA Robotics, we talked goal, as I mentioned, is a perfect balance of our flexion and extension gaps. We create the plan before enacting it, and we know exactly what we're getting as an end result. And you can see, again, a planning screen, and to the side there, as I see that, you can tell there's 6 millimeters cut off the medial side and 9 millimeters off the lateral. And that corresponds, in this particular case, to the amount of bone and cartilage loss that we saw at surgery. So we know when we're doing this operation, I'll know that these cuts are going to be right for the patient based on what their anatomy and what their x-rays look like. So now that we've done all the planning, we've taken that time, we know what our plan is. I hope you can see this picture well, but it's the robotic arm then comes in. So we guide the robotic arm in, and that then holds up the cutting block, which allows us to cut 3 things: the distal femoral cut, the proximal tibia. So essentially we're cutting the end of the femur, top of the tibia, to create the first space, which is the extension space. And then we actually mark, using the robotic arm, where we're going to be putting the cutting block to chamfer and fashion the femoral component for a perfect fit. So now we have all of that information. Now we enact it and make our cuts. So once our cuts are done, what we do is put in special trials, which are used to determine our polyethylene's thickness, and we proceed as usual. We cement in the smart stem. So I'd like you to look at the picture to your right, and if you notice the little stem on the bottom, that is a cemented smart stem, which I did point out to you, but that's the end result. And now that we've finished the case, the patient comes to the recovery room, and I wanted to talk about moving forward what we're seeing. So Persona IQ, it's a pacemaker battery. It lasts 15 years. It causes no harm to the patient. There's no increased risk of fracture. And I was cementing in implants that we call dumb implants years ago with a little stem to give extra support to the tibia. And again, same length, no risk. The battery does not do any damage. And I want to tell everybody that it does not track your location. I promise I will not know where you are. That is only to assess your walking speed, your flexion and extension of your knee, and how much your knee bends. It has nothing to do with location. So what happens? The patient is now in the recovery room. They're walking with a walker. They have their first cup of coffee. They begin stair training, and they go through the app on their phone, the My Mobility app. And they also get training in setting up the base station. And one of the things that I mentioned earlier, we're sending 85% of the patients home with all of this information. And if they have any problem, I have found that Zimmer Biomet has been incredible with this. When they're home, there's a helpline that they can call. They can certainly call my office, but there's a helpline to engage with these patients to make sure that the base station is set up and all of the technology is running perfectly. And ZB has been great on that front. We have somebody working behind the scenes to make sure that the patients are very happy with their technology. So what does the smart stem do? And here you see it. The patient gets alerts to the recommended post-operative exercises, which I mentioned earlier. So each day they'll tell them what exercises, the videos are included. And the patient and the surgeon can follow their recovery curve. So you can see here, we have access to walking speed. We have access to step count, cadence, stride length, and functional range of motion of the knee and the tibia. So all of these things the patient has access to, but so do I. So my protocol is to check these curves of all of the patients who I have on a weekly basis and make sure that I'm seeing progress and that my patients are doing well. So it allows for improved patient engagement through the entire process. It allows me to chart my patient's progress. and it certainly can allow for early intervention through the Epic or My Mobility. I can reach out through the chart. Hopefully in the future we'll be able to reach out directly through the phone, or in my case, sometimes I even have my staff call the patients and bring them in for a visit. One of the things in knee replacements that I've seen for 26 years is there is a slight chance of having patients need a manipulation of their knee to improve their motion. I have not seen one manipulation using ROSA robotics, and I feel that has a lot to do with the way we're balancing the knee replacement and the way we're opening up the flexion gap to allow the knee to bend. So if patients are doing really well, we can even skip the 6-week appointment and they can come in at 3 months. So advantages of robotic surgery: less pain, as I mentioned earlier, less need for narcotics. That is the case. I'm not giving as many narcotics now to my patients. And in fact, some patients can do it without narcotics: Tylenol, Toradol, anti-inflammatories. And I believe this is related to less ligamentous work during the operation. Years ago, we have to do the cuts, do our ligamentous balancing, and that was what I would call ligamentous releases that would lead to more pain in patients. So we have seen this in our practice over the last 3 months. Again, very exciting for me. Less narcotics, patients doing better. The ultimate goal for all of those involved. So advantages of robotic surgery: more range of motion because of our ability to balance the knee, as I mentioned, and ensure equal and open flexion and extension gaps. And the picture to your right, you can see that that was the old way to do it. We would instrument the femoral canal. We would run a rod directly up the center of the femur. So we're opening up at the femoral canal. That can lead to more bleeding, more pain, and also we're making cuts before we really know what the anatomy is. So then we make the cuts and then we have to fill in from there, rather than knowing what we're going to get and doing the job perfectly from the very beginning. So 6 months of data. I just found this out the other day, and again, I'm very happy, proud to report to you that after 6 months, and I had 3 months of traditional total knee with Persona IQ, and then 3 months of total knee with ROSA and Persona IQ, we're seeing 6 degrees more range of motion with the robot. That's a significant amount of range of motion. In my mind, can lead to either a good knee or an excellent knee. So those 6 degrees do mean a lot. Early results: range of motion is higher than the regional network. So we're doing a great job on Cape and in our region. I'm extremely proud of this work, and it's been a team effort for sure. From the very beginning, the help that I got and support from Cape Cod Healthcare to get the robot here, to all those involved at the hospital, from physical therapy to nurses, to the head of the hospital, all involved to make sure that we had the My Mobility app running and working smoothly, and to the VNA nurses who go out to the patients and help set them up the base station. So everyone involved, this has been a team effort and an incredible way of a team engaging and finding out the best way to improve the patient's outcome and the experience. So future directions, also very intrigued and excited about this. We're looking to collaborate with Brown University, where I did my training. All of the data is now stored in the robotic brain, and we're going to be able to analyze the patient data between surgeons and institutions. So Brown University versus Falmouth Hospital versus different doctors. And what our ultimate goal is to determine what preoperative plans lead to the best results. And we're going to continue to strive for continued improvement. So each knee will know what cuts are done and what cuts and how we balance those ligaments lead to what patient outcomes. Very exciting stuff. So future directions, I'll be back. This is kind of the matrix, but I wanted to talk to you about it. I'm also very interested in this. There's going to be a way for us to use glasses, CAT scan based, where we can actually see a hologram image of a hip and then be able to guide the implants in around that hologram image. So that'll be something for our future, and I will keep you posted on that in the future. And finally, robotic surgery. I've been doing traditional instrumented total knees for 25 years. I would not have switched and continued the endeavor unless it was showing significant superiority, which it truly is in our early results, and I'll continue to analyze that meticulously. I would say now that 100% of my knees are done robotically. If patients said they don't want it that way, I would let them I go to another surgeon, because I really feel that committed to it being better. And I'd like to say that I'm living proof that an old dog can learn new tricks, and I'm not a dinosaur. So I want to say thank you to everyone who attended, and thank you for your time and attention, and I will answer questions as we go. Are all patients candidates for the ROSA robot and Persona IQ? Pretty much every one of my patients is a candidate for the ROSA robot and the Persona IQ implant. Yes. Okay, I'll leave that one. And I'll repeat these questions. Does someone with AFib have any issues with medications used before or during surgery? So patients who have AFib typically are on blood thinners before. Eliquis, I'll stop that 72 hours before the operation, and then I'll restart the blood thinner after the operation. So special consideration for those patients. What happens after the Persona IQ battery runs out? Nothing. The battery will run out, but the knee replacement will still function beautifully and not impact the patient's health in any way. So we don't have to remove that. It can stay in for a lifetime, which we anticipate. As a new treatment method, it is covered by Medicare. Yes, great question. All of my surgery is covered by Medicare. Have you used ROSA to replace other total knee replacement? That's a great question. The answer to that is Zimmer Biomet is looking at new technology and ways to have a platform to use the ROSA robot as a way to do revisions. I still do a fair amount of revisions in my practice, and we are looking at that, and I think it's, again, something for the future. Hopefully I can bring that back here at our next meeting. Can you have a ROSA without the smart? Yes, so great question. I have patients who don't want to use the smart implant, whether they're not tech savvy or they're just worried about having the implant. That's totally fine. I can still do the ROSA robot without the smart implant, although I would encourage, and I try to get every patient that I see in my office who I'm booking for surgery, to use both the ROSA robot and the PIQ. Is Persona IQ one size fits all? No, the Persona, the little stem is a small stem, so essentially it is, but it fits the anatomical alignment of patients, even the smallest cases where I'm going down to women who are tiny. I have not had any issues with getting that little 30mm stem in. Prior to the 30mm stem, there was a 50mm stem, which has changed because that was a little bit harder to get in, but I have not had any problems with the 30mm stem. Does new total knee method reduce knee clicking? That's a great question. The answer is yes, I believe so. Because what happens is patients in the past who had knee replacements who functioned well didn't have their ligaments perfectly balanced. So through a range of motion, they will hear a little bit of clicking as the metal and the plastic touch one another. So now I feel that the robotic knees that I'm doing when they come back have less of that side-to-side play and therefore less clicking. Can I walk up steps immediately after returning home? Yes. Before you return home, we have everybody go directly and train with a physical therapist and train on stairs and go up the stairs before they actually go home. So we'll have patients whose bedrooms are on the second floor, and we can get them up those stairs once they get home. And I give everyone after surgery a tuck-in call, I call it. So all of the patients who go home same day, I'll call you at night and make sure that things are well, meaning your base station is working, your pain is controlled, and that the VNA has come in to evaluate you. Is age a limitation to qualify? So the way I see it is I typically start to cut knee replacement off, hip replacement off in patients around 85. But I don't base it on chronological age as much as their overall health and well-being, so physiologic age. So if you're 85 going on 70, absolutely you can have a knee replacement. But if you're 70 going on 95, I don't think I would do it. So yes, age as well as overall physical health is very important. On average, how long after surgery does the pain last? With this new technology, patients are very comfortable within the first, well, right after surgery, and they might have a mild amount of pain within the first week, but usually by 2 weeks, patients are feeling great. And then 6 weeks, light golf balls, 3 months, pickleball, 6 months, I have them skiing down a mountain. And I have patients who have run the Falmouth Road Race on their knee replacement. I've had patients who've run the Boston Marathon on their knee replacements. So, let's see what that says. At this point, we conclude the event. I got it. At this point, we conclude the event, and I have to read a couple of sentences before we can end the night. If you have any questions after this evening session, please free to email them to outreach@capecodhealth.org, and we will follow up with you directly. And to learn more and view tonight's recorded event, please visit us on the web at capecodhealth.org/knee. Thank you, everyone. I appreciate it.